Thank you for joining us for our training, An Overview of Schizophrenia and Psychosis, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder training to nursing facilities nationally at no cost to the nursing facility. And now, I am happy to introduce our presenter for today, Mr. Brian Stevens. Brian is a licensed professional counselor and the founder and CEO of Talk Forward, which provides psychotherapy and executive consulting services. Brian has experience in behavioral health for over 30 years and has extensive executive management experience. I'll now turn it over to Brian to begin the presentation. Thank you.
Well, hello, I'm happy to be with you today, and we're going to have a quick overview today of schizophrenia and psychosis. What we're going to do is hopefully you're going to walk away with an understanding of schizophrenia and psychosis, be able to recognize and understand signs and symptoms of schizophrenia, and be able to understand appropriate responses of engagement for the residents that we serve. So what is schizophrenia? Schizophrenia is a serious mental disorder that affects how a person thinks, feels, and behaves. It's classified as a thought disorder, and it really, of the mental illnesses, is the one with the most global impact upon the individual who has it. It is a lifelong disorder, meaning that somebody has schizophrenia, they will continue to have it. Across their life, it will continue to be something that affects them. Usually we see late teens or early 20 onset for schizophrenia. Males tend to have a younger onset for schizophrenia, though women may have a secondary onset in middle age around menopause. Now, late life onset of schizophrenia is actually pretty uncommon, and what we see if we see psychosis in late life is that it usually has some other causes. So let's talk a little bit then about psychosis, because I think psychosis is what people most connect schizophrenia with. So the National Institute for Mental Health defines psychosis as a collection of symptoms that affect the mind where there has been some loss of contact with reality. And I noticed on the poll, most of y'all said that psychosis is a loss of contact on reality. So good job on that. During an episode of psychosis, a person's thoughts and perceptions can be disrupted, and they may have significant difficulty in recognizing what is real and what is not real. And what might that look like? So that might look like things like hallucinations, delusions, even difficulty understanding somebody else's affect or emotional content. So psychosis is definitely one of the symptoms of schizophrenia, but not all people with psychosis have schizophrenia. Because it's part of schizophrenia, we often see psychosis beginning in young adulthood. But people can have a psychotic episode younger, older, and it can be part of many disorder illnesses. Older adults with neurological disorders, for instance, are at high risks of psychosis. And of course, psychosis can be a symptom in older adults that are not part of a physical or mental illness, or that are part of a physical or mental illness that emerges later in life. So we can see it as some diseases of older age, including Parkinson's, Alzheimer's, and some of the other related dementias. And of course, I think as we know, right, we can see delirium in the elderly from something as kind of simple as a urinary tract infection. So just because somebody has psychosis doesn't mean that, oh, they have schizophrenia. Schizophrenia really is we have to be able to diagnose globally, with psychosis being part of it. So what are some of our symptoms of schizophrenia? And the symptoms of schizophrenia fall into three broad categories, and those are positive symptoms, negative symptoms, and cognitive symptoms. And so the question becomes, well, what do we mean by this? So positive symptoms, unfortunately, do not mean good symptoms. They mean symptoms that are additive, while negative symptoms mean symptoms that take away. So positive symptoms, I think, are some of the classic things that we think about: hallucinations, delusions, and disordered thinking. So hallucinations are when the person is experiencing senses, activation of sensory systems in the brain of things that are not there. The most common is hearing voices. And that can be anything from voices just in silence, or even mishearing things, for instance, on the television. You can also have visual hallucinations, smell hallucinations, tactile hallucinations. The reality is any sensation we can have hallucinations for. And what is really amazing about these is they've done MRIs on people with having hallucinations. And in fact, the parts of their brain that say they're hearing voices, that are responsible for processing speech, are active in the brain. So these are very real experiences to the people having them. We only know what our brains tell us. And for these people, those parts of their brain are active. Delusions then are the disordered or distorted thinking. And delusions can be evident, and of course the classic are paranoid delusions. I think people are out to get me. I'm being hunted. There's some sort of big conspiracy that's interacting with me. You can also see delusions where people might think somebody's been replaced. We can see delusions with a misunderstanding of reality. Maybe I think the TV is talking about me, so ideas of reference, or those people over there are laughing. They're laughing about me. And so it's this distorted thinking about the way the world works. And that even can be, I'm being hunted by demons, or, and of course, if you think about it, if you see demons, it might make sense that you think you're being hunted by them. Disordered thinking is when the person is unable to really be coherent in putting their thoughts together. And we kind of see this if the person's having a very bad episode. And it's real attack on executive functioning. And when we see this with somebody who has disordered thinking, it's often very difficult for them to follow directions. And it really can lead into some of the cognitive symptoms we'll talk about here in a moment. Negative symptoms, then, again, these are the takeaway symptoms. What does this mean? So they can have a flat affect. So what we can see in people with schizophrenia is almost immobile facial expressions, monotone speech, lack of other physical expressions when they talk, and they can just seem they may or may not be depressed, but they can certainly seem depressed and have a very slow interaction. Also, with this flat affect, right, they're not projecting an emotional state. We can also see a difficulty in reading other people's emotional states. So the person may just keep talking, even though the person they're talking to is sending off all sorts of nonverbal, I'm done talking now, signals, and the person with schizophrenia is unable to pick up on that. Certainly a diminished ability to initiate and sustain planned activity. What we know is schizophrenia interacts with the dopamine system, and if we don't have enough dopamine as the neurotransmitter, it's very difficult to initiate and engage in activity. So there can be a lot of not engaging with others or engaging with things that they say they're going to do, or even doing basic household tasks like washing the dishes. And you can also see infrequent speaking, low levels of interaction with others. Even when they're prodded and forced to interact, the person may have difficulty interacting with others. Of course, there may also be internal stimuli going on. They might be hearing voices or having other things that they're attending to. Cognitive symptoms, and this kind of leads out of some of the disordered thoughts, right, can be poor ability to absorb and interpret information, and then make decisions based on that information. So an inability to really plan and move forward, being unable to sustain attention and stay on task. And this can have quite difficulty remembering and following instructions, which could literally be, they say they're going to get up and go do something, and they are self-distracted, or have that inability to, I'm getting off the couch to go to the kitchen to take my medication, and I can't even get to the kitchen before I forgot what, in fact, I am doing. So what are some behaviors we might see that support these things within a nursing facility? So number one, what we can attend to, and I think appearing to respond to hallucinations is kind of the number one thing to look for, because this is one of the first things we see with schizophrenia. So if somebody's responding to hallucinations, they may well be talking to themselves due to hearing voices. So they might be talking, and it looks like they're talking to another person, or they might be saying shut up, or they might be talking back. You may see people appearing to listen to somebody else during conversations. Who are they having a conversation with? Including staring intensely into empty space. I've worked with clients and I'm talking to them, and it's very clear they appear to be looking at and listening to something that's not there. I had one client who's really in a bad way, who wanted to prove to me, to fit the delusional pattern, that the client was dead, turned to a person who was not there, took a photograph that didn't exist from that person, and acted as if they were putting something down on my desk and pointed to it and said, "This is my proof." So that was somebody really disconnected from reality. We may also see people responding to odors that are not present. I had another client who very much smelled things that weren't there. It took us a long time to realize it, but was constantly cleaning with bleach, and their apartment would always smell of bleach. And it finally dawned on us that what was going on is much like somebody might put on headphones and listen to music to drown out voices. This client was drowning out the odors they were smelling with the bleach smell. You can also see people hyper-focused on details. And this can go with the delusional thinking. And you think about, there's all sorts of details that we ignore, we take for granted. But I've seen clients really focus on barcodes or lot numbers for medication. And I don't like that lot number. I don't want to take that medication because it's got that lot number. This one thing got slightly moved in my room, and somebody must have moved it, and just gets hyper-focused on one small thing. And that's a challenge because it just doesn't seem like a big deal to us, but for whatever reason, it's become very big for them. And as I talked about a little bit earlier with affect, people can become unable to process normal social cues. This can lead to somebody with schizophrenia really feeling quite intrusive, and very much like that they're not listening to cues, like a salesman ignoring your nonverbal cues. They're just not picking them up. Of course, disorganized speech and behavior. You can see people with tangential speech, where they kind of bounce from thing to thing, where their behavior is disorganized. They don't seem to be able to do simple tasks, such as put away clothes, or even get dressed. They can be slow to process information or process instructions. And one of the things then that we can see, it's very hard for them to do things quickly. Might not be able to provide solid historical information. If we think about, I've got delusions, I've got other things going on, they may not have the ability to really understand what it is that they're trying to relate historically, or get it wrong. Of course, they can appear paranoid. If somebody has paranoia, that often can come out. They're talking about people being against me. We had a couple of clients, I remember, who really needed to go to the hospital, but didn't think they needed to go to the hospital. that we were able to talk them into it because we were able to assure them quite legitimately it's a locked building and we're not allowed to tell anybody that they're there. So they actually felt like it was a safe, secure place where the people chasing them couldn't get at them. And of course, the final thing when somebody's psychotic, is having this psychosis with schizophrenia, is they can behave in unpredictable ways. They're not necessarily going to behave the way we expect them to when we know them when they're in a non-psychotic state. So what can you do? You've identified that somebody is having some sort of symptoms or psychosis. So very immediately, be patient. It's very easy to get impatient, but getting impatient will not help the situation at all. We want to be able to speak slowly with clear instructions. Don't make the multiple requests at once. They need one request at a time. And so again, that goes with being patient. You may be standing with them doing one request at a time. We want to try and avoid confrontation. We don't want to deny hallucinations. Don't want to argue with them about things. We don't want to argue about their delusions. Ideally, we want to go with their perceived reality whenever possible. Obviously, we have to ensure safety first. So it's like, nope, I'm not letting you out of the facility. But in general, what you want to try to do is not have confrontation about their reality right now. What we want to do is primarily listen to what they're saying and help the resident feel assured that he or she is safe is really critical, because they're often we're looking at people who are scared. Now, full-blown treatment of schizophrenia requires an assessment from a doctor or supportive, like a PA or somebody. It's needed when they're showing signs of psychosis. And that might order things such as antipsychotic medication in the short term or for ongoing care. Test to rule out other medical conditions, and treatment of other medical conditions may clear psychosis, like a UTI. And I want to make a quick comment on antipsychotics, atypical antipsychotics. A lot of medications labeled as atypical antipsychotics are used for treatment of other things than psychosis. A client who's taking an atypical antipsychotic like Zyprexa or Abilify or Geodon or Vraylar may or may not have schizophrenia or any other illness that causes psychosis. They were originally created to deal with psychosis, but what we have discovered is they impact depression, bipolar disorder, a wide variety of things. And frankly, they're quite good in depression that tends to be more vegetative. So you can't assume we understand a diagnosis based upon the use of antipsychotics. There are some non-pharmacological interventions that we can do. Social skills training. If somebody's had a psychotic episode, they often have a reduction in their social skills or their coping skills. So being able to help them train and retrain is very critical. Coaching, problem and symptom-focused interventions. And of course, we can always engage in talk therapy if there's somebody who can be able to do talk therapy with them. What you can do today, right now, like when you leave, is make sure that you educate. You're doing that right now for yourselves. You want to train the entire team on a proper schizophrenia diagnosis. So the whole multidisciplinary team. And what are the signs? What are the symptoms and supportive responses when working with these residents? We want to make sure that they're getting an appropriate level of psychiatric care. If somebody does have schizophrenia, they probably need to be on some medication for the rest of their lives. And we want to make sure that communication is going throughout the entire interdisciplinary team. We want to assess the stimuli that's in the nursing facility. If residents have a diagnosis of schizophrenia, they will benefit from predictable routine and a calm, stable environment. And I think one of the things that I really like, if we can provide a calm, stable environment for anybody, but certainly with people with schizophrenia, is it makes it easier to detect agitation if things are calm. You think about if the water of the pond is smooth, it's a lot easier to see where a fish jumped in or jumped out than if it's all churned up at once. And then therapeutic activities. We really, we want to be able to encourage our residents to have activities that are going to promote mental stimulation, help them with social interaction, and focused on their well-being. And these can include things like art therapy and music therapy, different cognitive exercises, group activities. And if these are tailored to the resident's skills, needs, and abilities, we're really able to do those person-centered care and support them. And of course, we want to make sure that these choices are part of the resident's care plan, and then that's known by the team so that the team knows what we need to do to take care of the resident. So I hope this has been a good initial overview for you on schizophrenia and psychosis. And now I am going to turn things back over to Derek.